Who is he, if anyone can name him? His name has already been written here. See, he is Paul Janssen. Okay. Paul Janssen was the person who actually developed haloperidol, and he was also the person who was involved in the team who developed risperidone. Okay, he was the chief of the team which developed risperidone, and he founded Janssen Pharmaceuticals, which is now a part of Johnson and Johnson. Okay, so this was about the history, how who all were involved, and see, he was involved in developing haloperidol. So if you look at haloperidol, it is a very pure inhibitor of D2 receptor. Okay, and they have been trying to develop an agent that can be given at home. Chlorpromazine were given to people who were admitted at a mental health setup or in institutions. So they started developing an agent which can be given at home. Haloperidol was one such agent which was developed by Paul Janssen and his team, which actually can be given to patients at home. But there was something which actually diverted them from developing another set of molecule that had actions apart from D2. There is an additional receptor which they started focusing, and then they led to development of something which is called as risperidone. Can anyone name that receptor? It can be a vague guess also. You don't have to be specific. If you can name that receptor which they started focusing. Okay, so Krishna, you are correct. It was 5-HT2A. That was the receptor they started focusing. And if we look, this is risperidone. And just by adding this part, it becomes paliperidone. Okay. So if OH group is added to risperidone, it becomes paliperidone. Although we know that this is the receptor that was into focus by this group, but getting into the specifics that we need this receptor to develop risperidone is something different. Okay, so actually they started developing haloperidol. So why this receptor was chosen? Let's look into that history. So there these agents actually make a lot of significance, and it will help us to understand why this receptor 5-HT2A came into the picture. Why they have chosen this receptor. This receptor was chosen because of some of the observations which was done by this team, and these observations we are going to just have a look. Okay, so see, early interest in serotonergic agent stemmed from preclinical literature. Okay, that it demonstrated behavioral effects of dopamine receptor antagonist, like for example haloperidol, which induced catalepsy. See, haloperidol. which is a pure D2 receptor antagonist, it causes catalepsy. Fine. So, what they found when they started doing trials, when they added an agent to haloperidol, which was having 5-HT2 receptor antagonism, they found that this effect of catalepsy can be modulated. Modulates catalepsy. Okay. So this was the preclinical trials they were doing. And the agent that they chose was, initially it was a preclinical trial. So they chose an agent that was PIPA. I'll write it here. Pipamperon. Pipamperon was the agent. Now they did this observation. So this was the observation which was made. Now, based on this observation, they started thinking that this receptor is having some kind of role by which they are able to reduce this effect, this side effect per se. So they started developing an agent which will be having this property so that they can be added up to the FGA, the first generation antipsychotic. To test this, they developed an agent having 5-HT 2A receptor antagonism plus D2 receptor antagonism, but was a weak D2 receptor antagonism. This was the first agent which they developed. They tried to combine these two receptors. Okay, this was this agent. This was cetoperon. Okay, this was cetoperon, this agent. Based on this observation, they developed this agent, cetoperon. Okay, now see, cetoperon was developed, but it was a laboratory agent. It doesn't used to last long, and the effect in the clinical trials was also very less. It didn't show significant effect in human beings. So now they were pretty much sure that this agent does work. So they have to develop something which will be similar to this receptor and can also act for a longer period of time and can show efficacy in human beings. So in this quest, although they yielded positive result, they developed another agent. In this line only, they developed another agent. And they developed a agent with 5-HT 2A receptor antagonism plus 5-HT 2C receptor antagonism, and they mixed it with haloperidol because haloperidol was their star product. And they got positive results with it. This agent, can anyone name the agent which was mixed with haloperidol? We have studied it in pharmacology MCQ. It is ritanserin. With this observation also, they came to the conclusion that okay, even we are adding it to a strong D2 antagonist, still we are able to get positive results. So the development of citoperon stopped after some time, and they focused on developing something which is having these two properties. And in that quest, they actually developed risperidone after multiple trial and errors. So risperidone, you can say it is a agent which is having D2 receptor antagonism plus X, and this X is 5-HT 2A 2C antagonism. And this was the logic behind developing risperidone, that because of the observation that they made, that adding on another receptor antagonist that is related to the serotonin pathway, they are able to develop something which will be more effective in reducing EPS, and also can focus on side by side, there won't be any uh, decrease in efficacy as far as positive symptoms are concerned. So this was the reason. Okay, I hope it is clear. Okay, and when with this agent, when they did the open label trial, placebo open label trial, positive result was observed, obtained, and with risperidone also, they also obtained positive result. So ultimately, we got risperidone, and it was developed by the same company, Janssen and Janssen. And in which year it was made? Can anyone can write down in the comment section, or can let me know in which year it was made? It was developed in 1993. So it's also a very new agent. It is not very old. Fine. Now let's look into the bioavailability, sorry, the pharmacokinetics, and we'll talk about various important aspects. See, it is available as oral, also available as liquid formulation. It is also available in depot formulation. Today we are going to cover every depot formulation that is available in market. It includes everything that has been launched in past year also as a update. Depot, liquid, and oral. See, it goes rapid absorption, and the bioavailability is 70%. Fine. And the peak plasma concentration, just give me a second, just a minute. Okay, just a minute. I'm really sorry. Yeah, the peak plasma concentration is achieved in 1 hour. Coming to the metabolism, it is being metabolized with by CYP 2D6, and what is the name of the metabolite? Anyone? What is the name of the metabolite? 9 hydroxy. Correct. So it is 9 hydroxy risperidone, which is also known as paliperidone. See, we have already discussed this. This is the group that has been added. Okay. So it is just the same. The structures are same. The only thing is that a hydroxy group has been added. Now see, what is the T half? T half is 20 hours. Now why I am focusing on this? Because see, when we discussed olanzapine, it had metabolites, but olanzapine metabolites were inactive. Okay, but risperidone is having active metabolites. Remember this. Also, the T half is 20 hours. When we compare it with olanzapine, it was 31 hours, and when we compare it with clozapine, it was 12 to 16 hours. This is olanz, this is clozapine, and quetiapine is 6 to 8 hours. But it is able to act for a longer duration, quetiapine, because of kiss and run hypothesis. Fine. Now, it is again excreted through urine. These uh, these are the basic important thing that you have to know as far as their pharmacokinetics is concerned. Okay, see, you have to know these things. And since we have discussed quite a lot in last class also regarding uh, what are the various kind of interaction that happens with 2d6 receptors, so we are well versed with these things. Okay, now let's move ahead and we'll look into the pharmacodynamics part. So we all know that it does block 5-HT2A receptor. It also acts on D2 receptor. It also acts on H1 receptor and also on alpha 1 and alpha 2 receptor. These are the major receptor that in which they act. If you have listened to the previous classes when we were discussing drugs, we have all discussed what are the various side effects associated with these sort of receptor blockade. Can anyone help me to write down everything? Okay, you can speak also. You can write it down in the comment section also. I would just like to please to help me out in completing what are the various associated side effects with each of the receptor. Come on, it's easy. H1, it's very easy. Sedation, dizziness, weight gain. D2, it is also easy. EPS. What about the others? Come on. You all know. Try to just note it down. Think about what can be the issue. Come on, hyperprolactinemia, correct. Good, Vineet. Okay, yes, yes, yes. It is also to do with weight gain, Elsa, correct. Amal, you are also correct. Alpha with hypertension, correct. make your brain work more. Come on, think much more. Sexual dysfunction, that is also correct, Jyotirmay. We all have discussed these points in last section of drugs. So we don't have to worry much. Okay. What about alpha? Something more we have to discuss about it. Okay. And because of HPL also, na, hyperprolactinemia, it causes sexual dysfunction and galactoria. Okay, note it down. And yeah, first dose hypotension is very key thing that you have to note. First dose hypotension associated with palpitations. That is why whenever we prescribed, whenever we prescribe risperidone, because of the first dose hypotension, always keep it in your mind as a good practice method. Whenever you give risperidone, specifically in adolescents and 55 years old patients, try to start with a minimum dose. Like for example, if you're giving tab risperidone, on the very first day you can give the half tablet, and then after 1 or 2 days you can increase it to 1. Other additional thing that you can do is whenever you ask the patient to take risperidone, ask them to sit on their bed for around 2 to 4 minutes, and then they should get out from their bed. Because of the first dose hypotension, it can happen that the patient might fall down. So always remember, start with minimum dose in these patients and ask them
Yeah.
to get up from bed after sitting on bed for around 2 to 4 minutes, so that they don't fall down because of the hypotension. The chances of hypotension are increased in these kinds of patients. Okay, always remember this. Anything more? Yeah, there are something which is like we have to be aware about very low propensity to cause QTC prolongation. It is there, but it is very low. Okay, now this is what we are done. Okay, now let's look into the interactions. So now it's your turn. The ball is in your hand. 2d6. Come on, just let me know. We all have discussed multiple times now in your chat section. Come on. What are the drugs that you should be vigilant when you are giving risperidone along with it? Come on, you all know. Have a look at your books also. No issues. Just let me know. I'll write some of the agents so that you can also start thinking. Ah, very good, Amal. Very good. Fluoxetine, paroxetine, and correct, carbamazepine. And see, I would like to mention one important drug, bupropion. Keep a check when you are giving bupropion along with risperidone. It does have correct. Ginkgo biloba is one of those agent also which actually inhibit 2d6. So ginkgo biloba is another agent that you have to be aware. These are nutraceuticals, but As far as clinics are concerned, all SSRI, they have to be vigilant, specifically with these two, with anti-seizure medication or anti-epileptics. Carbamazepine should be given special importance. This should also come into your answer. And as far as nutraceuticals are concerned, ginkgo biloba is another agent. Okay, all of these actually increase the level of risperidone level. No need to mug up everything. You just have to know what is very commonly practiced in clinics, what is very commonly practiced in OPD. Okay, otherwise what will happen, you if you keep on remembering everything, you won't be able to remember whole of the drugs, because as we are discussing one by one, it is easy for us to give focus on every agent, but when we try to recall everything, it becomes a very tedious task. Fine. Now this part we have covered. Specifically, I have kept this patient. Okay, EPS is one of the things that you have to be aware while prescribing risperidone. Next is metabolic side effect. Okay, now let's look into see, we have also discussed KT trials now. So again, I would like you to focus minimum to maximum weight gain by agents. I keep on revising all these things because so that it becomes well, like you all become well versed with these things so that you don't have to go back again and again. KT trial, the agents with minimum to maximum, they are risperidone, olanzapine, quetiapine. If you look, these two cause more weight gain as compared to risperidone. Olanzapine and quetiapine causes more weight gain as compared to risperidone. And in this trial only, there are two agents that caused decrease in weight. They were, anyone can name one of the agents? Ziprasidone, correct. Ziprasidone, and there was another agent, perfenazine. Various categories of obesity we have discussed when we were discussing olanzapine and risperidone, so we won't be discussing it this time. Okay, just remember these important things. There are some other points I would like to mention. So see, these are other points, important points given in your APA Textbook of Psychopharmacology, 6th edition. What are they? See, risperidone and paliperidone, both of them do take care of positive symptoms. Also, they have shown efficacy in reducing some of the negative symptoms and some of the cognitive symptoms. These two are mainly attributed to 5-HT, to a receptor mediated mediated dopamine release. and specifically in the frontal cortex. Okay. Also, another thing that has been mentioned in the latest textbook is that they have found role of alpha 2 receptor antagonism, that this is also the method by which it improves negative symptom. Details are not available per se, but they have mentioned that alpha 2 antagonism by risperidone improves negative symptom. And this was based on the study in which they found that FGA, first generation antipsychotic, if added with an alpha 2 receptor antagonist like idazoxan, it decreases negative symptom. So based on this, they have found this, that this receptor occupancy by risperidone helps to improve the negative symptom. Negative symptom improves. Okay. Now see, if we look why risperidone is having more EPS as compared to clozapine. Okay. Risperidone has more EPS because D2 receptor occupancy is 50 times more as compared to clozapine. With haloperidol, 10 to 20 times more as compared to haloperidol. Okay, these are the important points that you should be remembering. Fine. Now let's come to the formulations. Tablet form, it is available. What are the strengths in which it is available? Come on. Now it's your turn to answer. No, no, no. Sorry. It is correct. You all are correct. 20 to, so sorry, 10 to 20% of haloperidol. This is the difference. Hmm. Okay. 0.5 mg, 1 mg, 2 mg, and yeah, it does come in 3 mg also. Okay. Syrup, syrup formulation. What is the dose? Correct, Krishna. 1 milligram per 1 ml. Fine. It is a tasteless, colorless liquid. Now, this agent is also preferred because of the depot preparation that is available. Hmm. What are the depot preparations? First one that we all commonly use, it is Consta preparation. Okay. See, Consta preparation came pretty early in 2002 and 3. So 2003 was the year in which Consta preparation came in the market. Risperidone Consta. That was the company name. Consta, it came in 2003. Now see, it was indicated for schizophrenia maintenance or bipolar disorder. So indications was in schizophrenia, maintenance, and in bipolar disorder 1. This was the two indication that was approved by FDA for Risperidone Consta. Now, if we look the interval, the time interval at which it was to be applied was 2 weeks. So after a gap of 2 weeks, you have to apply the injection. Okay. We are done with the indication. We are done with the interval. Important thing is now see injection site that was mentioned in the package insert of the drug was it has to be given in as IM formulation in IM form in deltoid. It can be given in deltoid and gluteal. We prefer to give it in gluteal region, but in package insert it does mention gluteal and deltoid. But what we commonly use that should be remembered. If we look into the C, the doses in which it come, it is available in market. Initially, when it was released, this dose also was there. Okay. Now, it in Delhi it is available in 25, 50, and 37.5 also. Okay. Now, the important thing is, okay, let's write it here only. It comes with 21 gauge needle and the volume is 2 ml. All the doses are dispensed in 2 ml form. This is the volume that you need to inject. Okay. See, prior important thing is like prior to depot risperidone consta, you have to give oral supplementation. You have to give oral supplementation. And minimum duration of oral supplement before giving consta was 21 days of oral supplement with oral risperidone. Okay, oral supplementation with risperidone was 21 days. So 21 days you have to give oral risperidone, following which you can give this depot. So 21 days is 3 weeks. Okay, 21 is 3 weeks. It is 3 weeks. Fine. Now see, once you are done with this, you know that 3 weeks you have to give oral supplement and you have to again after you are done with 3 weeks you can give the depot injection. Also, this agent needs reconstitution. All of you who all have used Risperidone Consta, it requires reconstitution. which means the powder has to be mixed with a diluent. Okay, I hope you all have understood what I was explaining in this agent to Risperidone consta. Okay, now let's move into the another agent which was developed. So the another agent which was developed was Perseris. Perseris. Now see, Perseris is another agent which was developed in 2018. Okay, Pawan has asked a question that what is the dose equivalent that we can calculate? Okay, now see, dose equivalent where you can calculate. So I'll explain that first. So according to Maudsley, remember this, why I am saying Maudsley, this is 14th edition. The dose equivalent is 25 milligrams of Consta is equivalent to oral 2 mg. Fine. 37.5 milligrams of Consta is equivalent to, come on, anyone? 3 mg. Correct. Correct, Vineet. 3 mg. 50 milligram is equivalent to 4 mg. Correct, Amal. And if we want to make 6 milligrams of oral, what is the dose that we have to give for in form of this depot? No, Amal, that we can't do. So it is not available for 6 milligrams. You don't give 75. Okay, that much is not required because that much doesn't come. So you can't give more than 2 ml of injection. You can give 2, 2.5 max. You can't give 4 ml or 5 ml of depot. Okay, so it is not available for 6 milligrams. 6 milligrams, there is no formulation available. This is according to Maudsley. If you read the package insert, the company which releases Risperidone, it is released by same company, the original company, Janssen. Okay. Here, they don't mention any kind of oral dose equivalency, but Maudsley does mention it. So if you look package insert, if you look package insert of Consta, no oral equivalent was mentioned. But in Maudsley, it has been mentioned. Okay. So remember this 25, 37.5, 50 accordingly. Fine. And we don't have for 6. And also remember package insert of Consta, there is no oral equivalent mentioned in the original package insert. Now let's look into this agent. This is also important. Okay. Hmm. Perseris. Perseris is another agent which was released in 2018. Okay, Perseris is a subcutaneous form of injection that is to be given. It's not IM. Okay, it is subcutaneous. So again, the indication was the same, but here it was not approved for bipolar initially. It was approved only for schizophrenia. It contains risperidone only. Okay. Now, why I have uh, placed a packet over here, the backside of the, see, this is the location where you have to give injection. Abdominal, subcutaneous. So subcutaneous, abdominal. Okay. And injection interval is, anyone? What is the injection interval? Injection interval is, like it was 2 weeks for Consta, it is, come on, it is 1 month. In the package insert, they also mentioned upper arm. Yes, correct, Divya. It's 4 weeks. Come on, correct. Upper arm has also been mentioned. 1 month or 4 weeks. Now let's move ahead. So we have discussed this. Now see, injection volume in Consta was 2 ml. Here the injection volume has reduced. Now see, first we'll look at the dose in which it comes. See, this is 120 milligram. It comes in two formulations. One is 90 milligrams, and one is 120 milligrams. Okay, 90 milligrams, the volume is 0.6 ml. It is less than 1 ml. And here is 0.8 ml. These are all pre-filled syringes. It comes in, see, it's a pre-filled syringe. And the important thing is, see, powder is there here. Powder is located here. You just have to take the diluent and pull the plunger behind. And you have to do to and fro 60 times. Mix, you have to mix 60 times. Very unique for Perseris. Sorry, Perseris. 60 times you have to mix it like this. Okay. This came in 2018. Now see, 90 milligram is equivalent to, anyone? Oral equivalents? Anyone can give a guess or can answer it? Oral equivalent? 90 milligram? It is? Come on. Do give it a try. No, Krishna. Something more. Come on. Yes, Pranshi. Correct. It is 3 milligrams. And 120? Come on. 120? 120 is 4 milligrams. Yes, Pranshi. It's correct. Also, very unique thing. No oral supplementation needed before giving Perseris. This was very unique. You can directly start. Fine. Also, this is not 21 gauge as we usually read. It is 18 gauge needle. This needle is 18 gauge. So powder is free filled. You have to take the diluent, pull the plunger back, The diluent, you have to make 0.6 ml and 0.8 ml. You have to mix it 60 times, count it, done. You can inject. Fine. This is the company which released Endeavor, Indivior. Yes, yes, yes. Oral 3 mg. Okay. Next we have Rikendo. Rikendo came in 2023. Rikendo. If you look at Rikendo, Rikendo also comes with a pre-filled syringe. See, it's also having a pre-filled syringe. So Rikendo was, first we should write it down. It came in 2023, and the indication was same as that of Consta. Okay. Now, see, it is again, the interval was 2 weeks. So it is something similar to, always remember, it is something similar to Consta. Something similar to Consta. Always remember. The site of injection was again that of Consta. It was IM to be given over gluteal region. Okay. And the dose it was available was similar to that of Consta. So what are the doses? Okay. And same kind of conversion was there for Rikendo also. Similar. This is the oral one. Okay. You have to constitute, see, this is again a different kind of syringe. 20 gauge. Volume is 2 ml. Again, remember, it is same to as that of Consta. So volume 2 ml. Okay. Now, why it was developed? See, okay, I'll just show you that this is the vial in which, okay, you can connect it and you can get the diluent in the powder, mix it up. It is a pre-filled syringe. See, oral supplementation. Remember this when we discussed oral supplementation with risperidone is needed in, like, prior to depot, you have to give oral supplementation. Here also you have to give oral supplementation. But there was a benefit of giving oral supplementation in Rikendo. When you give oral supplementation to depot Rikendo, the oral supplementation has to be given for only a period of 1 week. Only 1 week of oral supplementation is needed, and then you can give Rikendo. Okay, fine. Now see, one thing more that I would like you to know that, see, after completing everything, I'll just tell you. User D. This was another thing which came in 2023. So we have discussed Consta, Rikendo, Perseris. Three we have discussed. This is the fourth one. User D. Last year only it came. Again, the indication is for schizophrenia. Fine. Now, two doses are available. First of all, where we have to give, it is also a, is it an IM or a subcutaneous? Come on, just look at the picture and let me know. Yes, Krishna, correct. It is subcutaneous injection to be given over, where we can give again same abdomen and upper arm. And see the volume, injection volume. What is the volume? It ranges from 0. It is very less, 0.14 ml to 0.7 ml according to the dose in which it comes. Also, the interval of injection is either 4 weeks, that is 1 month, and or 8 weeks or 2 months. Okay, I have already taken it from this site of UZD. See, and it is ready to use. You don't have to mix. And UZD comes, 1 month preparation comes in these formulations. See, 50, 75, 100 and 125, and 100, 150, 200, 250. This is 50-50 equivalents for 2 months. This is 1 month preparation, 1 monthly preparation. This is 2 monthly preparation. And this is the equivalent dose, oral one. See, okay. So up till 5 you can make. And it is again a 21 gauge needle. Okay. What about the oral supplementation? It is not needed. You can directly start, just like Perseris. Okay. Now, so these are the sites. Important thing about UZD, that you don't have to rub after you give. Don't ever rub. Okay. Don't heat up the site. Also, this I have taken from Perseris, but yeah, always you can look, just because it can also be given for UZD also. This is the site that we are talking, abdomen and upper arm. See, just have to stretch the skin and place it there. Okay, stretch the skin just like you give the subcutaneous injection. Pull it up, give it. The volume is also very less. And yeah, there is some bump that might be observed. So you have to tell the patient that, yeah, a bump will be there, but it will gradually settle down. See, UZD is very specific because, see, initial first 24 hour, it reaches a very nice therapeutic level, and it is there for 6 to 24 hours initially. Therapeutic levels are reached very fast. And then what happened? This is why you don't need an oral supplementation with this medication. It's not needed because it reaches to that therapeutic threshold in first 24 hour itself. And then according to the formulation that you have given, you can if you can give, this is 100 this is the 1 monthly preparation and this is the 2 monthly one. See, the plasma concentration dips, and then once you give it again it continues. So you don't have to worry about the therapeutic threshold level once you give UZD. It achieves therapeutic threshold depending on the patient's built from 6 to 24 hours. So you don't need any oral supplement. Now, let's look at something which was released last year only. So this was UZD was not released in 24. Sorry. It was 23. It is RIS1. RIS1 is the latest of all. It is again a depot, and it is indication is schizophrenia. RIS1 was released, and the thing is about RIS1 that it is again a 1 month injection given in IM form over deltoid, over gluteal, and it comes in these two kind of syringes are there. One syringe is this in which powder is there, and other syringe is this in which solvent is there. So what do you do? And one is having 21 gauge needle and another is having 20 gauge needle. There are two types of needle that is there. So you take both the syringe and then you mix up and down. Okay, this is how you do. You just take both the syringe, keep it like this, and then you, with the plunger, you push the liquid and then you push the powder so that you can mix it through this. Fine. No oral supplementation is required. Also, there are two doses in which it comes: 75 milligrams, 150 milligrams. 75 milligram is equal to, see, 0.55 ml, and 150 milligram it is equal to 0.73 ml, less than an ml also, and it is equivalent to oral, it is 3 mg, and oral it is equal to 4 mg, and interval is 1 month injection interval. Okay. Also, the number of cycles in which you require to mix, 50 cycles is needed. 50 times as compared to per series where you have to mix for 60 cycles. 60 cycles, or yes, 60 cycles. Okay. So this is it. Is it 0.85 or 0.55? Here. Okay. 0.55. 0.55. 0.73. 75 milligram is the, this is the volume that has to be injected, no? And this is the volume. And this is the oral dose equivalent. Okay. That's it for today. We have covered Risperidone, seen a bit of history, seen a fair amount of formulation. We know the interaction. We know the various latest form of all the depot that is available in the market till last year. Nobody has covered it. We are good that we discussed it. I want each one of you to be there, much updated than your peers, so that you don't feel that you are well short of any other knowledge. You are up to date. You are all here to learn. If you don't know, good. From today onwards, you know everything about risperidone depot, about the doses, how it acts, how it works, what are the metabolism, what are the historical facts about it, what are the indication, you all know it. So this is about risperidone.